subsection webinar, uro-oncology subsection webinar on bladder cancer. So we have all the reputed faculty, national and international faculty for this webinar. We have with us Dr. Sanjay Adla, who is the chairman of the uro-oncology subsection of Urology Society of India, and Dr. Brusabanu Naik, who is the secretary and the council members of this urology subsection. The topic is very interesting for all of us, especially for postgraduates. They can learn so many things from this. It is divided into three parts: non-muscle invasive bladder cancer and muscle invasive bladder cancer. Talks by international speakers. So before I start the webinar, I request the Dr. Keshav Murthy sir, who is the president of the Urological Society of India, to give his brief address.
Thank you, Dr. Surya Prakash, and good evening, everybody, and welcome to this webinar by the Uro-Oncology section of the Urological Society of India. The topic they are covering today is about bladder cancer. I think the entire spectrum of both muscle invasive and non-muscle invasive is being covered by eminent uro-oncologists from India and also two international faculty, Dr. Ananya from UK and Dr. Shemek Deshmand from USA. So it will be very interesting topics. I think all the postgraduates will be immensely benefited by this, and we hope to have good interaction in this webinar. Over to you, Dr. Suri.
Thank you, sir. Now, I also request Dr. Uttam Mete, sir, who is Honorary Secretary of USI, to say a few words before we start the webinar. Uttam, sir.
Good evening, everybody, and thank you, Dr. Surya. And here to welcome you all. And you know that this is a focused topic, and I congratulate the subsection chairman, Dr. Sanjay, and the secretary, Dr. Bushbhanu, for curating this program. What I can see that it has been focused to one area, that is a bladder cancer, and that is commonly it's being faced for our day-to-day practice, and for the residents it will be definitely a very good webinar because they will definitely have any case during their exam. So with these few words, and I also welcome and thank the international faculty member who have joined to improve our webinar content, and I'm sure it is going to help us and going to add some value to our webinar. With these few words, I welcome you all again, and then we can start the program. Thank you, Dr. Surya.
Thank you, sir. So without wasting much time, now I invite Dr. Brusabanu, who has made a lot of efforts in curating this wonderful program. Over to you, Dr. Brusabanu.
Okay, thank you, Dr. Surya. Actually, good evening, everyone, again. So I'd like to thank the USI and the Indian School of Urology for giving the opportunity to the uro-oncology subsection. On behalf of the uro-oncology subsection, we have actually chosen to do this on bladder cancer. So as you already know the program, it's been divided into 3 sessions. Each session will be moderated by 2 moderators. And the first session will be a non-muscle invasive bladder cancer. Then there will be 2 talks by the eminent international faculty, Professor Danismond from USA and Professor Ananya Chaudhary from CISPAM Radiation from UK. And the last session will be on muscle invasive bladder cancer. The first session will be conducted by Dr. Kebal Patel and Dr. Rakesh Sharma. That will be on non-muscle invasive bladder cancer. I request everyone, please, because we have only 2 hours time. Please, everyone, stick to the 5 minutes. I know this is very less time, but please stick to the 5 minutes time. We'll have 10 minutes discussion at the end of the session, and then the whatever questions that will come in the chat box that will be discussed by Dr. Surya. But before that, the conveners can also discuss the questions after the session for 10 minutes. So now I invite Dr. Rakesh and Dr. Kebal Patel, please, to introduce the first speaker to start the session.
Thank you, Dr. Brusbanu. So without wasting much of the time, let us begin our session today. And to present the first talk, I'll invite Dr. Amitabh Singh. Amitabh sir is a senior uro-oncologist at the Rajiv Gandhi Cancer Institute. So, and he will be talking about TURBT, how to choose a proper technique. Over to you, Dr. Amitabh Singh.
Good evening. Thank you. Thanks for invitation. So can you hear me? I'm audible?
Yes, you're audible.
So thanks to USI, ISU and Uro-Oncology section for giving this opportunity. So can you see my screen?
No, still not, sir.
Okay. Visible or not? Is it visible or not?
No, sir, you are not visible. You have to share, no? I mean, there will be share option.
Yes, yes, I said it. One second, one second. Second. Oh. Now can you see my...
No, sir, no. I think we can.
Amitabh, if you're facing any
I think, sir, you can go to the
yeah,
second
you
talk.
can
I'll just
go
see.
to the next speaker. Yeah.
Yes, sir. Yes.
Yes. So, yeah, Dr. Prashant Nayak is also here. For the next talk, I invite Dr. Prashant Nayak. He is a senior robotic and uro-oncologist at AIMS Bhubaneswar, and he will be talking on en bloc versus piecemeal TURBT. Over to you, Dr. Prashant.
Yeah, thank you, Dr. Keval. Thank you for the opportunity. Let me share my screen. Right. Is it seen?
Yes, we are able to see it.
Right. So it's a 5-minute mandate. I'm going to be talking about what is I have no conflicts of interest here and whatsoever. So the introduction is about what is this holmium laser enucleation resection? What is its role in the contemporary era? How is it better than URBT, if at all? Gold standard is TRBT, but we know that there are certain issues with it. Tumor can fragment, tumor cells can scatter. There are a lot of artifacts which impair histopathology. There are issues with incomplete resection, obturator reflex, and bladder perforations can be there. So these have led to a resurgence of interest in this enucleation technique. So what is the concept? The idea is we remove the tumor in one piece along with the detrusor. Holmium laser is being used. When it is used, of course, monopolar has been used, bipolar has been used. It has a low penetration, excellent hemostasis. You circumferentially incise it and then you enucleate it. There is a video also running. We can keep seeing that. So this kind of en bloc retrieval, it preserves the architecture. Pathology staging accuracy is there. The studies have shown it has a high detrusor muscle inclusion rates, reduced artifact. It is critical for substaging of the E1, also decreases the need to do re-TRBT because we are able to get this hip muscle within this. Also, it prevents piecemeal resection. It is more like the R0 resection. So there is a theoretical reduction in the risk of implantation, which has been borne out now. There are certain trials which say that the recurrence rates possibly are lower. I'll be coming to that. Other is perioperative safety. It has lower rate of obturator reflux, bladder perforation, shorter catheterization, better hemostasis. And why this prevents obturator is because the laser penetration is not deep enough to stimulate the obturator. However, it is not a one-size-fits-all kind of solution. There are limitations in reach, anterior wall, dome, multiple tumors, learning curve is there. There is the equipment cost of both the laser platform as well as the availability. Initially, there might be longer operating times. What is the guideline position? Both EAU and NCCN. NCCN is not saying anything about it, but EAU says it's an alternative. They're not yet mandated. It has just ended, and URBT remains as the reference technique as per EAU. This is coming to some of the evidence. So I'm talking about a lot of meta-analysis because a lot of trials have been there, a lot of meta-analysis says that. So this was the International Journal of Surgery 2022 meta-analysis, which showed that the bladder perforation, obturator nerve reflux, residual tumor, and need to do re-TURBT all were significantly reduced. However, urethral stricture detrusor muscle as well as recurrences did not show any change as compared to a bipolar conventional TURBT. So there was no change in recurrences. The same journal put up an updated systematic review in 2024 end. So this said that there was a decrease in recurrence rate at 6 months and at 1 year. So this is significant. In addition to other advantages, this technique showed an oncological superiority in an updated meta-analysis that the 6 months recurrence and the 1 year recurrence rates are possibly lower. Again, we know the reasons that we are doing an en bloc removal and the tumor scatter and possible reimplantation is not happening there. So that is probably why there is an oncological benefit. The same journal put up a review and an updated meta-analysis by the end of 2024. So after this, so there have been other, like lot of RCTs are there. So combining this RCTs and combining all this, what you call meta-analysis, there was an umbrella review. This also came out in 2025. It included 9 eligible meta-analysis and 9 RCTs. Again, it showed that the NMIB, when you do an enucleation resection, lower rate of bladder perforation, superior performance for detrusor muscle presence, catheterization time, lower risk of residual tumor, and higher rate of 3-month and 1 year recurrence-free survival. So there are obvious benefits oncologically, perioperatively, and I think this technique should be adopted in the larger interest wherever it is feasible. Thank you. I can stop sharing here. Thank you. Thank you.
Thank you, Dr. Prashant. So we'll take the questions in the end. So the next topic is, I would like to invite Dr. Amitabh Singh, who's going to speak on TURBT. How do you choose monopolar, bipolar laser? Amitabh, you have five minutes.
Yes, sir. Let me check, sir, whether I can share this thing or not right now. Okay. Now, can you see the slide, sir?
Yeah, we can see it.
Okay, sir. So good evening, everyone. The topic given to me is the TURBT, how do you choose monopolar, bipolar, and laser. So we all know the monopolar energy has been always the gold standard for TURBT, but it came with a lot of advantage also. Like the cost is very low, it is very widely available, the technique is familiar to most of surgeons, and it is very effective in tumor resection. But it comes with a lot of side effects also, because it can cause TUR syndrome also, it can lead to significant obturator nerve reflex, and it can lead to higher perforation risk also, and it leads to more thermal artifact in the pathology. So there has always been a necessity which felt that we should have a better energy source which can just avoid all these side effects of the monopolar cautery for doing TURBT. And later on, we got the bipolar energy, laser energy, and hybrid knife, which is the new kit on the block as an energy source for the TURBT. So the question is how to choose energy source. Various factor plays the role, like what is the tumor size, what is the location, what is the number of tumors. So is patient is having pacemaker, whether his heart and kidney functions are normal or not, whether patient is on any blood thinner or not, and what is the volume of cases in the center, and the cost which he can afford, the center or the surgeon can afford. So coming to the literature, so I'll be just for the time's sake, I'm just giving very limited literature. So this is the single center randomized trial which tried to compare the monopolar and bipolar energy with conventional TURBT, because bipolar TURBT has been shown promising role in eliminating obturator jerk, eradicating TUR syndrome, and providing better hemostasis. So in this trial, 147 patient randomized into 75 in monopolar and 72 patient in bipolar arm. Most of the tumor were in lateral wall, and they strictly did TURBT under spinal anesthesia without doing any local obturator block or any general anesthesia with muscle relaxation. And there were enough balanced distribution between the residents, junior consultants, and the senior consultants in the cohort. But surprisingly, only 50% of the patient had obturator jerk, and whereas in bipolar arm, almost 60% of the patient had obturator jerks. Whereas the secondary endpoints were like bladder perforation, hemoglobin drop, transfusion rate, recoagulation and clot retention, and resection time. And there was no difference whether the monopolar was used or the bipolar was used. Though clinically not significant, but the virtue of the physiology in bipolar arm, there was no TUR syndrome reported in this randomized trial. whereas there were significant advantage in eliminating severe cautery artifact with bipolar energy source. So how do you choose that whether you should go for the monopolar or you should go for the bipolar energy source? So if patient is having a small medium sized tumor with standard anatomical position, and if patient is healthy, then I think monopolar is better choice. But if patient is elderly patient having cardiac and renal dysfunction, tumor size is big, and you expect that resection time would go more than 1 hour, or there are chances of having TUR syndrome, then better to use bipolar energy source rather than using monopolar source. Although later on in this meta-analysis, 8 studies were included, almost 6 were randomized trial, one was prospective and one was retrospective study. They compared monopolar and bipolar. And in the result, it has been shown that bipolar fared better than monopolar in terms of operating time, post-operative stay, estimated blood loss, drop in hemoglobin, catheterization time also. Terminal damage means the cautery artifact in the histopathological specimen. So there were lesser obturator nerve reflex also, there were lesser bladder perforation also, and the biochemical, this post-operative recurrence-free survival was better in bipolar arm compared to the monopolar arm. So that now the jury is basically is going in favor of bipolar energy source compared to the monopolar energy source. Then what happened when the laser was compared with the bipolar and energy source? So this was the basically a multi-center randomized trial in block resection trial. So in this single center prospective randomized study, actually it was a subgroup analysis, post hoc analysis, where single center patients were analyzed between the monopolar and bipolar and laser enucleation in block resection of the bladder tumors. And it has been found that there is no difference between the detrusor muscle yield, whether the monopolar was used or bipolar was used or thulium laser was used, although the incidence of obturator nerve reflex was all zero in thulium laser, whereas they were almost same in monopolar and bipolar. In fact, it was more in the bipolar cohort. When the conversion was seen, that it was most in thulium laser, especially for anterior bladder tumor, and the artifact was same because all these TURBT and resection were done in block resection, so there was no artifact seen in histopathological specimen whether monopolar was used or bipolar was used or laser energy was used. So how do you decide between the monopolar, bipolar and laser? So if the tumor is on the lateral wall where you feel that there can be obturator jerk, there can be chance of bladder perforation, then better to use thulium laser. And especially for the tumor which are lesser than 3 centimeter. If they are more than 3 centimeter, then the laser, they are not preferred energy source. Although now recent studies says that you can morcellate these tumor or you can still divide these tumors, but still the oncological efficacy needs to be proven. If the tumor is on anterior wall or the dome, then better to use energy source like bipolar or monopolar energy source because the conversion rate is higher with the energy laser energy. And if the tumor is on the posterior wall, still any energy source can be used, whether laser, bipolar or monopolar, depending on the size or the cost of the procedure. So for the dictum, because the literature is too much, for the sake of the time, I have summarized it. If you are focusing on the outcome and if you are comparing the energy source, then monopolar is the worst energy source in terms of bleeding, perforation risk, obturator jerk and specimen artifact, whereas bipolar and laser are better than monopolar. Especially laser fares much better compared to the all energy sources in terms of every outcome if the tumor size is less than 3 centimeter. So this is a very famous reel.
You have, oh, now I have 240. However, now that I am associated in this American oil venture, I hope to be able to afford many more.
Feel about that, Mr. Clampy?
Well, with that many wires, a fella could be pretty sure of coming home at night and finding at least one in a good mood.
So this is basically, it is always better to have multiple energy sources. But if you can afford only one energy source, I would say that monopolar is the affordable energy source, but better do TURBT under general anesthesia with muscle relaxation. But if you can afford, then better to have bipolar and laser energy source as well. Thank you.
So thank you, Dr. Amitabh. It was very enlightening talk. For the paucity of time, I would request the consequent speakers to stick to the time. Questions we'll take at the end. So I'll straight away invite the next speaker, Dr. Tarun Jindal. and he is a robotic uro-oncosurgeon from Calcutta. So, Dr. Tarun, over to you.
Thank you, Dr. Keval. I hope my slides are visible.
Yes, please.
Right. So the topic, I thank the Indian School of Urology and the Uro-Oncology subsection to have me. The topic which has been given to me is of a very important exam point viva question. So what are obturator jerks and what are the methods to prevent that? So obturator jerk is a very unique complication of transurethral surgery, specifically TURBTs, and you can occasionally have the jerks during TURPs also, specifically in the large glands and median lobes once we are tackling those. Obturator jerk is an important cause of surgical morbidity and can often lead to incomplete resection. It's not very uncommon, as Dr. Amitabh just showed, that approximately 16 to 20% of the cases will have an obturator jerk and will lead to subsequent problems also. It's higher in the lateral wall tumors, and it is also more common if you're not using a general anesthesia along with the muscular relaxant. So it is basically a sudden involuntary adductor muscle spasm. It is also called adductor spasm. It occurs because of the direct stimulation of the nerve by the electrocautery, which is being used during the resection of the bladder tumor. So why it happens? Obturator nerve is a nerve which originates from L2 to L4. It runs along the lateral pelvic wall and very close to the inferior lateral wall of the bladder. The nerve basically supplies the adductor muscles of the thigh. And once you stimulate this nerve through the bladder via the virtue of the using of say a monopolar current, it leads to the adductor spasm and the contraction, which is known as obturator jerk. Why spinal anesthesia fails? Spinal anesthesia blocks the nerves, but once you're stimulating the nerve directly with the electrocautery, the muscle will still go under spasm. So this basically leads to a failure of the spinal anesthesia to prevent obturator jerks. The clinical significance of this particular problem is that it can lead to bladder perforations. Majority of the times it is extraperitoneal, but it can even be intraperitoneal. This leads to fluid and urine extravasation. There can be severe bleeding because you might be damaging the nerve along with the obturator vessels, or there have been case reports in which the surgeons have actually damaged the iliac vessels also. It can lead to incomplete tumor resection, and along with that, it can also lead to tumor dissemination. The problem can also be life-threatening in severe cases. The risk factors, the position of the tumor is extremely important. Majority of the tumors which are there in lateral are the tumors in which you can expect obturator jerks to happen. In thin bladder walls and specifically in the bladders, if you are during the resection, you have overdistended the bladder and you are cutting on the lateral wall, the chances of current going to the obturator nerve is much higher. Use of monopolar electrocautery again will lead to increased chances of an obturator jerk. Or if you have not used any kind of nerve block, or if you are doing it under spinal anesthesia, this can also lead to stimulation of the obturator nerve and obturator jerks can happen. So how do you prevent that? The most effective method probably is if you prevent it by doing the paralysis of the nerve. So you can actually block the nerve before stimulation. You can do an obturator nerve block. This reduces the jerk significantly and improves the surgical safety. There are multiple techniques by which you can actually block the obturator nerve, but the best technique is ultrasound guided along with the nerve stimulator. So you can precisely identify the nerve. You can do a nerve stimulation, you locate the nerve, and then you paralyze the nerve with a local anesthetist. The other method which we commonly use is the general anesthesia along with muscle relaxant. The muscle relaxation plane has to be deep. It is still not reliable in 100% of cases, but probably one of the best techniques is relaxant with general anesthesia. The other methods to prevent it is you can reduce your cautery current. You can use a bipolar energy, though it is controversial. I think everybody would have experienced that even with bipolar, we do land up with having obturator jerks. Avoid over distension of the bladder during TURBTs. You can also use intermittent cuttings, or you can use laser resections. Laser resections are probably never associated with any kind of obturator jerks. If the jerk does happen, you have to stop the resection immediately, empty the bladder, remove the chips as many as you can, and then you reassess the injury. You can ask your anesthetist to convert the patient into a general anesthesia, maybe repeat a muscle relaxant. You can repeat a neurogenic block, the nerve block, or you can decrease the bladder's distension and you can get away with the surgery. If the perforation occurs, I think Dr. Rishi will address that, what to do in that scenario. Thank you very much.
Thank you, Dr. Tarun, for the talk. The next speaker is Dr. Rishi, as is already mentioned. Dr. Rishi is going to speak on bladder perforation during TURBT, how to manage. The slides are already available. Dr. Rishi, you can start.
Hello, am I audible?
Yeah, you're audible.
Okay,
Please
so
start.
thanks ISU USI for giving me this opportunity. Now, a lot of it has already been covered by Tarun in the previous talk. Yeah, so basically there are four types of perforations. Type 0, which are there in about 50 to 60% of all over cases, where thin rim of the detrusor muscle still remains in the depth of the tumor bed, and basically we do not need to do anything else. The points of concern are when we reach to till adventitia or till perivesical fat, and then it's a very dire situation when the perforation ends up into the adjacent organ or the pelvic muscles or till the peritoneum. Basically, the incidence, if we look actively using cystography, it can happen in about 50 to 60% of the cases, but clinically speaking, it is thankfully rare in about 1 to 10% of the cases. The important point is that it can abort the procedure, it can preclude the intravesical therapy, increase risk of extravasation of tumor cells possibly, and then there is associated bleeding that can happen, which may become uncontrollable, and then additional treatment morbidity because of the extravasation per se. So all these things are important, and therefore the management of bladder perforation becomes really important, and one needs to be well versed with it. There are several intraoperative recognition points and even postoperative points, but the real red flags are that the sudden loss of bladder distension during TURBT, or if there is abdominal distension because of the fluid during surgery itself, or in the post-op period when the patient develops ileus and peritonitis, we must consider it as a bladder perforation unless proved otherwise, and we have to manage the patient accordingly. But even in a case where you see you visualize the perivesical fat, try and limit your procedure there and then, and proceed only when you are certain that the perforation has not occurred. What are the factors guiding the management? The factors guiding are whether the perforation is extraperitoneal, which most of the times it is extraperitoneal, and it happens because of the operator jerk, and the loop leads to the perforation on the lateral walls of the bladder. And in those cases, majority of the time, 95% time, they are extraperitoneal, thankfully. And then based on the timing of detection, whether you detected intra-op, early post-op, or late post-op, then the clinical management questions differ. And also you need to keep in mind whether you are dealing with a suspected case of NMIBC or MIBC, because if you are dealing with MIBC and the bleeding becomes uncontrollable, and if there are signs of peritonitis, one can talk with the patient and go ahead with the emergency radical cystectomy itself. And then there is a case of bladder blast, which is a specific injury in itself, and all such cases must be explored there and then to actively look out for any bowel associated injury that may have happened during the bladder blast. The decisions to be made for each of these cases intraoperatively, whether hemostasis is there or not. Generally, when there is a jerk, one specific bleeder may occur. So empty out the bladder with minimal irrigation. Just see if you can achieve hemostasis. Don't try to have a very clear output, but just coagulate the major bleeder vessels, and it should be sufficient enough that you are able to manage with the minimal irrigation possible. And then you have to decide whether the conservative management will do, which does well in most of the cases when the perforation is extraperitoneal. And you have to decide if there is abdominal distension and peritoneal fluid collection, then peritoneal drainage has to placed, and exploration, as I've already told. Mitomycin C, I will come in the next slides. So this is the basic overall gist of the presentation, how to manage. As I said, most of the perforations, minor perforations, they do not require any specific interventions except for a prolonged catheterization for 2-3 days. If you consider it is a major perforation, then the catheter may be kept for 5 to 7 days. And select patients with extensive perforation or uncontrolled bleeding may require emergency cystectomy. Intraperitoneal perforations, all of them must be explored. If you detect perforation in the early post-op period or late post-op period, the likelihood is that it has been a significant bladder perforation, and the patient may require drain. So consider drain with a low threshold. And if you have not already put mitomycin C, then avoid mitomycin C in these patients. The important question is what is the impact of these bladder perforations on the oncological outcome? There are several large series, all retrospective because we cannot have prospective data on these perforations. 1 to 800 to 1000 per cases, there sort of recurrences have been reported. So they are rare, but they do occur. There are other series which report near zero rates. In those cases where open repair was required, they have the strongest risk. So we don't really know whether the perforation during TURBT or actually the opening of the bladder with the during the exploration itself that led to the local recurrences. So that remains an open point of discussion. Whether you should put a mitomycin C or not, we are really looking at just a prevention of about 15 to 20% over 5 years. And this risk is improved mainly in the low risk cases. So therefore, we are not really gaining much by putting mitomycin C, particularly in cases who are higher grade or high risk. And also, if there is some seeding of the tumor cells, in our own study, we have shown that most of these cases do not end up having recurrences because these cells ultimately, extravasated cells ultimately get cleared out by the immunological mechanisms most of the times. So really avoid mitomycin C because risks, local side effects, including threatening necrosis, bladder, pelvic abscesses and peritonitis have been reported with mitomycin C. So if it is a large perforation, avoid mitomycin C. So finally, risk of perforation, how to reduce has already been tackled in the previous talk. And I can conclude by saying that bladder perforation is fairly common and often underdiagnosed and most of the times they are managed as usual. But wherever the surgeon thinks that he has perforated the through and through the detrusor, then keep the catheter for a longer time, avoid mitomycin C in most of the cases, and oncological outcomes are generally unaffected. So thank you.
So yeah, thank you, Dr. Rishi, for such insightful talk. Now I invite our next speaker. I think Dr. Amandeep is going to present talk on adjuvant treatment in NMIBC. Over to you, Dr. Amandeep.
Yeah, sir, good evening. Am I audible? And another slide seat.
Yeah, you are audible and slides are also very well seen. Please go on.
Okay, great. Thank you so much. I'm talking on behalf of Dr. Prakash. I've been asked to speak about adjuvant therapy in non-muscle invasive bladder cancer. The first step after you've assigned the diagnosis of non-muscle invasive bladder cancer to your patient is to risk stratify the patient because all patients are not the same. We have various risk stratification systems that are available. We have the one given by the American Urological Association. But in India, we tend to follow the EAU risk stratification more. Prior to 2021, the risk stratification was pretty straightforward, but this is what it has become post 2021. We do not need to memorize this, although some things are very exclusive. But what we need to do is go onto this nmibc.net, and this is the page that opens up. And then you pick up things from the histopathology report and enter. And finally, the calculator will give you which risk stratification category your patient belongs to. And there will be 4 categories: low risk, intermediate risk, high risk, and very high risk. And we'll see what needs to be done ahead. For your low risk patient, that single post-op mitomycin C that you had given when the TURBT was done is the end of treatment for the patient. That was ideally to be done within 6 hours for the patient. Mitomycin C is the most commonly used. These other 2 agents may also be used in practice. We would have avoided giving that if the TURBT was expensive, or as the previous speaker said, there's a perforation that was suspected. Or if the tumor appeared invasive, you would have not put the mitomycin C. And following this, there is no further treatment required for your low-risk patient. And we do a check scopy at 3 months and then at 12 months and then annually. When do you stop scoping is not known, but you should go until at least 5 years. For your intermediate risk patients, you have to give some more adjuvant intravesical therapy, which can either be BCG or MMC. We tend to use MMC when it is a low-grade intermediate risk patient. We tend to use BCG when it is a high-grade intermediate risk patient. It is given as induction, 6 weekly installations, and then maintenance for 1 year, 3 weekly installations at 3, 6, and 12 months for BCG. And if you are using mitomycin C, then we continue monthly installations for a year. For your high-risk patient, you have to give adjuvant intravesical BCG therapy. Here, we tend to not use mitomycin C. We give induction in the same way, 6 weekly instillations, and the maintenance goes on as 3 weekly instillations for 3 years, 3, 6, 12, 18, 24, 30, 36 months. So a total of 27 installations for the patient. We do a check scopy and urine cytology every 3 months in the first 2 years, and at every 6 months in the third year. And we also need to image the upper tracts once a year, either with a sonography or with a CT IVU. Now, a little more about BCG. So the Moscow strain is the one which is available across India. Most of us use it at the 80 mg dose. It has excellent efficacy. The 2-year RFS is around 85%, but there are issues with tolerance, and hence we try to reduce the dose to 40 mg or try to give a holiday to the patient, space out the installations, or sometimes it leads to drug discontinuation. We need to be aware of this definition, which is adequate BCG, which is defined by the IBCG as 5 of 6 induction doses plus 2 of the 3 doses of the first maintenance. So if your patient can take these 7 installations of the first 9 installations, that patient has received adequate BCG. And now if this patient is having BCG intolerance, you would probably not want to push the patient too much and lead to more toxicity. This is something new. The International Bladder Cancer Group has further stratified intermediate risk low-grade patients. So these are all low patients, but they fall under intermediate risk. So then you need to ask yourself these 5 questions. Is the tumor more than 3 centimeters? Are there multiple tumors? Has there been an early recurrence within 12 months? Are the recurrences frequent? And is there failure of previous intravesical treatment? And then you will probably get answers. You will have ticked multiple boxes. If you tick none boxes, you treat the patient like a low-risk patient. If you're taking 2 questions, you treat as an intermediate risk patient. But if you're taking 3 or more boxes, then this low-grade patient actually needs to be treated like a high-risk patient with prolonged intravesical therapy. What about intravesical gemcitabine docetaxel, which is being preferred because of BCG shortage and also BCG toxicity? So the data first came out for BCG intolerant patients, but now we have data for BCG naive patients also. This is the dosing that is used, 1 gram of gem retained for 90 minutes. The paper says 37.5 mg dosi. We get dosi as 20 mg vials. So we use 2 vials, 40 mg in 50 cc NS and retain for 90 to 120 minutes. The schedule is again 6 weekly installations and monthly installations maintenance for up to 2 years. Excellent efficacy again. 2-year RFS in that paper was close to 80%. And the toxicity is much better compared to BCG. So it is much better tolerated. And as you can see, 94% patients completed induction. And in 8% patients only, the side effects affected the schedule. This is something again very new. We only discuss about BCG as being the drug of choice, but the Potomac trial has been recently reported, which combined durvalumab with BCG. So durvalumab is a PD-L1 inhibitor, and it is said to increase the immune response that is induced by BCG in the bladder and leads to a sustained immune response. In this trial, they had 3 arms. In one arm, they combined durva plus BCG. Leave aside the second arm. And the third arm was BCG alone. 330 high-risk patients. And their primary endpoint was the DFS comparison between arm 1 and arm 3. And this is what the main results were. For the BCG only arm, the 2-year RFS was around 81%. It was improved by 5 percentage points for the durva plus BCG group. So to summarize, you risk stratify your NMIBC patient firstly. For your low-risk patient, no more adjuvant therapy after the single MMC. For your intermediate risk patients, give 1 year of therapy. Low-grade patients, MMC. High-grade patients, BCG. High-risk patients, give 3 years of BCG. Use the IBCG classification for intermediate risk, low-grade patients. And BCG plus Durva has on paper become the standard of care, but we've still not started using it so commonly in practice. Thank you.
Thank you, Amandeep, for the excellent talk. The last talk for the session is how to make BCG more tolerant and manage the side effects by Dr. Ravichandran from Bangalore. Ravi, your slides are visible. You can start.
Am I audible, sir?
Yeah, you're audible.
Good evening, everyone. So I'll be talking on how to make BCG more tolerant and to manage the side effects. Well, first is to understand the problem what this BCG is causing. Roughly around 30 to 70% of patients do develop side effects, and of which around 10 to 20% discontinue due to intolerance. This wide range is because of the heterogeneity in the geography of the study done and the different kind of strains and the doses that has been given. And many a times, this premature cessation of BCG increases the risk of recurrence and progression. So this BCG is not just a toxicity story, it is also has an oncological outcome story. And that's where the importance of able to reduce the BCG toxicity and managing those side effects so that patient can successfully complete the course of BCG comes into picture. Next, the main thing is to be able to predict the set of patients who have high possibility of enduring this BCG side effect. First is if they have a baseline high IPSS or a baseline severe LUTs, or if there has been a large tumor burden with multiple foci of CIS, those patients are at risk. Frailty, elderly age, and prior history of intolerance for intravesical therapies. Any hostile urethra, there may be a stricture, inflammation, they are at high risk. UTI, gross hematuria, bladder inflammation, or a very recent TURBT, probably trying to give intravesical BCG within a couple of weeks of TURBT, or if there is any traumatic catheterization, in these patients, they would be more prone to suffer BCG side effects. So the first thing is to be able to predict these set of patients so that we can take extra measures to prevent those side effects into the picture. And next, how do we prevent it? One, delay BCG at least for 2 weeks after TURBT and ensure by history, physical examination that they don't have a UTI. If required, a urine routine examination can be done. Ensure that they are not having gross hematuria and no febrile illness before any of the installations. And when you're trying to give BCG, make sure that there is no trauma to the urethra. It's gentle atraumatic passage of the infant feeding tube or any catheter. And most important is gravity filling of the BCG, which many of us overlook. We try to push the BCG in a quick manner, and those patients will try to endure it and then end up with a lot of side effects. This is a screenshot taken from the drug information leaflet of the OncoBCG produced by Serum Institute. And you can clearly see their recommendation is to instill this medicine slowly by gravity, and it should be retained for 2 hours. Patients should not ingest any fluid 4 hours before and 2 hours after installation, and should lie still for at least first 15 minutes of the installation. This, even I was not very sure about it. After having multiple conversations with doctors around, with Sanjay Agla sir, now after started practicing this gravity filling of BCG, I can safely say that the rates of side effects have come down significantly. And the other important part is to counsel the patients, prepare them beforehand so that they're able to psychologically manage these side effects. And last is to have a role of post-installation fluoroquinolones for a couple of days to reduce the side effects. Next, in case, in spite of taking all these preventive measures, if patient is having side effects, what do we do? As Dr. Amandeep has already mentioned, we can consider reducing the dose, not necessarily 120 mg, even 80 mg, or in some cases up to 40 mg is good enough. The crux of the issue is not the milligram of the dosage that it is going, but it's the colony forming unit. What has been established is anywhere between 10 to the power of 8 to 10 to the power of 9 colony forming units, irrespective of the milligram, is good enough. If we look at the OncoBCG that we use in India, each vial contains roughly about 1 to 20 into 10 to the power of 8 colony forming units. That is around 40 mg per ml. On the other hand, when you see the TICE BCG, which has been widely used in Western, they have roughly around 1 to 8 into 10 to the power of 8 colony forming unit. That comes in at roughly about 50 milligram. So most important is not the milligram, but then the amount of colony forming unit that is more important. And in spite of this dose reduction, if the patient suffers, then temporary delay rather than premature discontinuation. Do not discontinue, give a holiday, and then you can always restart. And the other modality is to switch to monthly maintenance spacing in highly symptomatic patients, unlike the SWOG of 3 weekly in 3, 6, and 12 months. And if we should stop all the maintenance doses altogether, is just the adequate BCG is good enough? Does our Indian patients have this concept of trained immunity? That needs to be studied further. And finally, in spite of all this, if at all the patient is having side effects, then we need to grade it, grade 1, grade 2, grade 3. Grade 1, they are mild to moderate, fever less than 38.5, likely for a day or two, not more than that. In those patients, we can get urine culture and essentially symptomatic management with anticholinergics, antispasmodics, and analgesics. In grade 2 toxicity, the LUTS is very severe. There is severe hematuria, fever high grade for more than 48 hours. Then we need to get urine culture, chest x-ray, and LFTs to ensure that there is no systemic toxicity of BCG. And accordingly, we may need to manage. In grade 3 toxicity, where there is a systemic infection or a solid organ involvement, in those cases, we need to be very aggressive. Along with supportive measures, anti-tubercular treatment like isoniazid, rifampicin, and ethambutol may have to be given for 3 to 6 months. And in very severe cases, a dose of prednisone will also be required. So to take home message, the dose reduction, not necessarily 120 mg, 80 mg, and in some cases even 40 mg, there is a decent evidence for our Indian patients. So that should be good enough. Don't delay. The delay is better rather than discontinuing. Give a holiday break, then restart for those patients. And the most critical thing is to recognize these red flags early, symptomatically manage them, counsel the patient, and then get them back on the scheduling. Distinguishing between manageable toxicity and dangerous toxicity is very, very important. And goal is not just to deliver the BCG, but to be able to complete the effective therapy for these patients. Thank you.
So excellent talk, Dr. Ravichandran.
Thank you, sir.
Now we have, I think we are already with the allotted time. Dr. Surya Prakash, do you have any questions in the chat box from the residents over there?
Yeah.
We can take 1 or 2 questions.
Yeah, there's a question from Dr. Manas Sharma. He is asking about, please highlight the specimen retrieval techniques in N-block TURBT. I think Dr. Prashant Rai can take this.
Yeah, so the specimen retrieval, generally we remove it in photo, but if it's a large tumor and it is not coming out through the resectoscope sheath, then we need to employ morcellation. So we did an in-house study to look at the quality of the specimen. So even if the specimen is morcellated, still the pathologists are happy because the absence of the carrying effects. So yeah, if it's a small one, it can come out through the resectoscope sheath. If it's a large, you need to morcellate and take it out.
Thanks, Dr. Prashant. So next question is by Dr. Sudhir Kumar Devana. In case BCG is not available for high-risk NMIBC, which intravesical therapy you will consider?
Amandeep.
Amandeep can take.
I think Amandeep is not there.
Ravichandran also can take this question.
Yeah, Amandeep is there.
Amandeep is there?
Yeah, he's there. He has another talk.
Sir, sorry, can I have the question again?
Yeah, if BCG is not available for high-grade tumors, which intravesical therapy would you consider?
Yeah, so then I would want to give gemcitabine docetaxel.
Okay.
As per the schedule that I mentioned in the talk. Yeah.
Fine.
Yeah.
Okay. There's a question from Dr. Jaspreet Singh Sandhu sir to Dr. Ravichandran. What is the role of fluoroquinolines in BCG? As he mentioned post BCG installation.
Post BCG installation, if they're having any irritative LUTs, there is a limited data for giving 3 days of fluoroquinolones for symptomatic improvement, sir. If there is any subtle infection, that will be taken care, sir. There is no solid data for it, but limited data.
So this is for prophylaxis for?
Yes. Yes, sir.
Okay. So do you have any guidelines to say for this? Is it evidence-based?
No, sir. There is a limited data, sir.
Okay.
I tend to give ofloxacin 2 doses, sir, at 8 hours after the BCG and the next day morning, only 2 doses. And that there is evidence of there is a randomized control trial to say that the side effect profile is lesser by doing that.
Okay. Thank you. I think Dr. Brushabanu, you can proceed with the next session.
Okay. Thank you, Dr. Kebal and Dr. Rakesh and all the speakers. So now moving on to the second session, which is actually an invited speakers from international faculty. So let me first welcome Professor Danasman. Good morning, Dr. Danasman, and good evening, Professor Chaudhary. So
Good
first,
morning.
the first talk will be the systemic immunotherapy in bladder cancer, both NMIBC and MIBC. So first, let me introduce Dr. Danasman. He is a professor of urology and medicine at Norris Comprehensive Cancer Center at the University of Southern California. And he is the director of urology, oncology, and clinical research. And he is part of many landmark trials in urology. And very recently, the SWAG trial on lymph node dissection, he was a part of the trial. So it's my honor to introduce him and invite him to speak on immunotherapy, systemic immunotherapy in bladder cancer, both MIBC and NMIBC. What are the benefits? What are the quantum of benefits, and what are the side effects? And are you over treating the patients? Dr. Danasman, please.
Great. Thank you. Thank you very much. Let me just share my slides with you. And okay, hopefully you can see that and you can hear me okay.
Yeah, we can see you very nice and your slides are visible.
Great. So thank you very much for the invitation. This is a timely topic, systemic immunotherapy in bladder cancer, because we're seeing increased use and increased interest in combination therapy. So I will go through some of the recent trials and sort of try to frame the benefits versus a potential overtreatment in some of these patients. So there's I think a paradigm shift. Systemic IO is rapidly moving into earlier curable disease states. As with any oncological treatment, we have something that works in metastatic disease, and then we're trying to move it into first localized disease and then into even the high-risk non-muscle invasive space. BCG has long been the king, and as we heard earlier, it's very, very effective. But a lot of patients still have recurrences, and we can improve on BCG, particularly for the very high-risk patients. So this is not an exhaustive slide. This is just an overview of some of the agents that are available. Of course, everyone's familiar with pembrolizumab, but there's citrilimab that was used in the Sunrise studies, and I don't have time to go into all those studies. But we see the interaction there. We know how it works. And each of these agents has been involved in some pivotal trial in bladder cancer that's sort of shaped our current thinking here. So these are, again, some of the ongoing and completed phase 3 trials for high-risk patients. You have the BCG naive space where we completed the bridge trial. This is gemdosi versus BCG. But there were 3 trials that looked at BCG plus immunotherapy. One was atezolizumab with Alban, Patomac, which we just heard about with durvalumab, and Patapsco, which we have not heard much about, but CREST we certainly know about, and then the SWAG 1602 is not immunotherapy based, but it was a Tokyo strain of BCG versus the TICE BCG that we use in the States. And then there's various other combination therapies that I'm not going to get into exhaustively, but that's sort of the next phase, I think, of these studies are these combination therapies and seeing whether we can improve the outcomes and yet have acceptable side effect profile. Now, the Sunrise studies are interesting as well. Again, I won't get into it just for the sake of time, but those are the pretzels that release gemcitabine in a sustained release format with a device that's placed in the bladder. Many of those trials were combined with citrilimab, which is a PD-1 inhibitor as well. So again, there's a lot of interest in this space, but we do have to be careful. Let's go through some of these BCG plus combinations. This is PD-1. Again, we know that BCG is very, very effective, but you can have recurrences in up to 50, 60% of patients at 1 year. And certainly by 5 years, many patients have it. I always frame my initial consultation with a patient that we're going to become good friends and we're going to be seeing you a lot. You have to give them the idea that this is an ongoing sort of chronic disease, and what we're trying to do is prevent progression of disease. And you can see, depending on your risk status, it's anywhere from 15% all the way up to 45% at 5 years, which is pretty significant when you think you have a non-muscle invasive bladder cancer to begin with. Many will become refractory to BCG, and there's increasing global shortages of BCG. We in Los Angeles have had a significant shortage of BCG for the past 5 years, 5 to 6 years, actually. And so we've had to pivot to either some of these clinical trials or even using gemcitabine docetaxel up front. The Bridge trial helped us in some ways, and other trials that are going into the space has helped us. This continues to be a problem for us, and we're now using recombinant BCG from Immunity Bio as an alternative to BCG. Okay, so adding IO to BCG, it's sort of this race, and all these three trials started around the same time. Alban, again, was the atezolizumab plus BCG. These are all BCG naive patients. Potomac, Durva, and Crest was the sasanlimab plus BCG. And these of all these trials, Crest sort of made the biggest splash. The recent meetings, and I wanted to go through some of the data for this. So this is sasanlimab, and what's interesting about sasanlimab is that it's a subcutaneous formulation, so it can be given in a urologist's office. The patient population was BCG naive, high-risk non-muscle invasive bladder cancer up to T1 disease with obviously no prior IO therapy. And the primary endpoint was this event-free survival. So you had these three combinations. You had sasanlimab with BCG induction and maintenance, sasanlimab with just the induction, or the standard BCG induction plus maintenance. So really trying to see what the benefits of each component is. And you see the results here. There is an improvement when you give sasanlimab with BCG and maintenance. But that comes at an event-free survival of 85% versus 80%. So you have at 2 years about a 5% benefit of the combination therapy here. So my talk was balancing the risk-benefit ratio of this combination therapy, and we'll look at specifically the AE profile. When you looked at the induction versus maintenance therapy, sasanlimab with induction versus BCG plus maintenance therapy, the difference was not as significant as you saw with sasanlimab with induction and maintenance. So if you just do induction, it pretty much looks very, very similar at around 36 months. So here's the pre-specified subgroups. I think this is important if you're going to just use it in some patients. It seemed to work in CIS patients quite well. And in high-grade T1 also worked quite well. The presence of CIS, again, was not significant if you just used induction BCG with sasanlimab versus induction plus maintenance. So you can't really substitute the maintenance BCG with sasanlimab and expect the same outcomes. So if you're going to use it, it would be sasanlimab with BCG and maintenance, and that'll give you the best sort of outcomes in this setting. When looking at overall survival, however, it really does not look very different. And that's because, we're not looking at death rates from this. We're looking at progression, and that probably takes more than 3 to 4 years to see any kind of difference. I think those differences come probably in a 10-year period where patients are getting progression and then finally succumbing to their disease. But as you can see, over 4 years the curves overlap, and there's really no difference in overall survival. Okay, let's look at the safety summary, because this is the most important part. Sure, we can add and get any benefit, 2, 3, 4, 5% or whatever it is. We want to see improvement, but at what cost? When you look at the grade 3 treatment-related adverse events with sasanlimab with BCG and maintenance, first of all, let me take you to the top of the table here. 97% of patients are having some kind of treatment emergent adverse events. We already know this. When we give any intravesical therapy, we have lots of side effects. But let's look at the grade 3s. You have 29% with a sasanlimab with BCG and maintenance versus 76% with BCG induction only. So, but if you give only BCG and maintenance, it's 6%. So very, very different. You have a significant increase in grade 3 treatment related adverse events. And some of these are serious. If you just give BCG plus maintenance, 1.4% serious events versus 17% if you give the combination therapy. Giving steroids, we just mentioned steroids for BCG, that's 1% in the induction plus maintenance. However, when you use the sasanlimab, it was 20%. So thyroid disorders of any grade, 17%. And when you use 17 to 20% when you use sasanlimab, whereas obviously in just induction BCG, it was very, very low. And you can see the rest of them from rash, hepatitis, pancreatitis, all in the sort of 3 to 4% range. So yes, it's safe. Yes, we give it, but you do have to keep this in mind. You know, the balance between the benefits versus the side effect. If 15 to 17% of patients are suffering from thyroid disorders and need for lifelong thyroid replacement therapy, that can be significant. All right, let's look at Potomac because it was a very similar trial. This was durvalumab and BCG administered as a combination therapy. There was randomization, 1:1:1. Same, very, very similar. Durva plus BCG induction plus maintenance versus Durva plus BCG induction or just BCG induction and maintenance. The primary endpoint here was disease-free survival, and then you see the key secondary endpoints there. And here's the sort of baseline characteristics of the patients, the very, very similar baseline characteristics with about a third of the patient having CIS, but significantly 58% of the patients, about 50 to 60% of the patients having high-grade T1 disease. So this is a high risk, very high risk subgroup of patients here. Here's your DFS curve, and you can see with the blue line up top is a Durva plus BCG induction and maintenance, so sort of combination therapy, and then the comparison group on the bottom with a hazard ratio of 0.68. Again, you're seeing about a 5% difference, 81% at 2 years, almost 2% versus 87% disease-free survival. So again, you're gaining a little bit of benefit here, but the vast majority of patients don't need the additional systemic therapy for an excellent outcome. So if you frame this for the patients, well, we can get you 80% disease-free at 2 years with BCG plus maintenance versus 86 or 7, and these are the potential risk factors. Most patients, I think, would choose just the BCG plus maintenance therapy. And if you looked at durvalumab plus BCG induction only, again, that difference was very, very small, and the hazard ratio was not significant. So again, time and time again, we are learning that maintenance therapy is important. And again, looking at the sort of high-risk patients, it worked in papillary disease and carcinoma in situ. In this case, it didn't seem to matter if you had carcinoma in situ present. So a little bit of difference between this and CREST. And again, overall survival looks no different, of course, as expected. And this goes out to about 6-7 years. So whether those curves continue to separate later after 8 years, I'm not so sure. Again, let's look at the serious adverse events. We've got 32% serious adverse events versus 19%. For the comparison group, discontinuation of 20%, 18% at least, and you can see, there's a lot of other treatment-related adverse events that are specifically attributed to the immunotherapy. These are the usual things we're used to: the dysuria, hematuria, polyuria, cystitis, UTIs, which look very, very similar. But when you specifically look at the immune-mediated adverse events, then they're very different. Again, you have hypothyroidism in about 10% of patients and none with the BCG. So again, the other ones are low, 2 to 3 to 5%, but this hypothyroidism seems to be much more prevalent when you use immune checkpoint inhibitors. So these are sort of side-by-side comparisons, 2-year event-free survival of 85% versus 87%, very, very similar for CREST and Potomac, and hazard ratios of exactly the same as 0.68. So yes, it does improve our outcomes at a cost. And I think you really need to just present this to the patients. So let's talk a little bit about the perioperative situation here. We have the neoadjuvant IO concept, which is really downstaging and then going on to radical cystectomy. The Pure 01 using pembrolizumab was really the conceptual landmark for this type of promise that we are eradicating somehow the micrometastatic disease. There's been several trials here, the IMvigor010, atezolizumab versus observation in adjuvant studies, Checkmate 274 and Ambassador. And IMvigor010, atezolizumab, again, did not, unfortunately, meet its primary endpoint, and whereas Checkmate 274 and Ambassador did. And Checkmate nivolumab has been in our hands since 2021 as adjuvant treatment post cystectomy. And here are the curves. The disease-free survival was very significant, 22 months versus 10.9 months for adjuvant nivolumab, given the patients who are at high risk. And the Ambassador is very similar, 29 versus 14 months. So these do work, but we're still overtreating some patients who don't need it. Unfortunately, at this point, it's very hard to determine who those patients are, but I think we're getting there. The Niagara trial, now, you have adjuvant treatment, and now you want to move it into the neoadjuvant space. So the Niagara trial looked at GemCis Durva compared to GemCis, and you can see a significant reduction in the improvement in the event-free survival at 12 months and 24 months of 68% versus 60%. So now we're talking survival. This is very different, hazard ratio 0.68 again. And so now, because we're talking survival, I think that improvement may be worthwhile for the immune checkpoint related adverse events. So it is setting a new standard, and this has been in use for us for the past year and a half. We've been using GemCis Durva as our neoadjuvant therapy with plus minus continuation of durvalumab post-operatively, depending on the pathology. Although in this trial, everybody was supposed to be on a continuation of therapy. And now we have EV-Pembro. And again, I'm not going to go into major detail here, but EV-Pembro initially in the cis-ineligible patients, and now, of course, as of GUASCO 2026, and just in February, we saw neoadjuvant EV-Pembro for cis-eligible patients in this randomized keynote study. This was a big presentation, and this is sort of the take-home message here. You've got at 24 months, 80% versus 66% in terms of event-free survival. And again, this is now very significant. So we're willing to take the risks of immune checkpoint-related adverse events for this benefit. And you can, this is also complicated by the fact that EV has its own set of complications and side effects, specifically neuropathy. But you can see the grade 3 treatment emergent adverse events are 75%, although it's 67% in GemCis alone. But these can be serious in about 60% of patients. So these treatments can be somewhat toxic. So just the last couple of slides here, mitigating overtreatment. We do have this major ctDNA revolution, so to speak. And now we need to be more thoughtful about who we treat, either in the adjuvant setting or even in the neoadjuvant setting. We have very powerful drugs available that can treat patients. So this is, I think, one of the most exciting trials that's out there right now. Matt Galsky is the PI for this, basically taking patients who are ctDNA positive and randomizing them between nivolumab, which is your Checkmate 274 approved adjuvant treatment, adding relatlimab, which is a LAG-3 inhibitor. If you're ctDNA negative, standard of care would be nivolumab, but then you could be randomized to surveillance. And if you have detectable ctDNA, then you go on to nivolumab. So you're saving patients any adjuvant treatment who are ctDNA negative. So I think we'll learn a lot from this trial. And the next sort of, I wouldn't call it a revolution per se, but sort of the next thing to look at is a utDNA. There's been plenty of studies showing that it is highly, highly predictive for the response to BCG. So there are a number of studies now looking at de-escalation approaches to UTDNA. So in the future, I think we need. It's not about finding more drugs. We do have very effective drugs. It's about smarter use of these drugs. We do have some AI biomarker predictive charts. There's one from one called CHI. These are computational histology that can help us differentiate between the response between BCG and gemcitabine docetaxel. We're actually using this it's commercially available, and we're using this at our center. So that's the end of that. I'll stop there. Thank you very much for your attention.
Oh, thank you, Professor Danismond. It was a very interesting talk. So I have a couple of questions, if you can take. So let me start with actually the muscle-invasive bladder cancer. We all know the immunotherapy has actually shown some positive data, both in NMIBC and MIBC. My question is, are you now routinely recommending to all your patients perioperative chemo immunotherapy, those who are actually the candidates for neoadjuvant chemo, to all patients?
Yes, great question. So yeah, the question is whether we're doing a combination of chemo and immunotherapy for patients with muscle-invasive bladder cancer, and then the answer is yes. We routinely are doing gemcitabine, cisplatin, and durvalumab. There are very few patients who are not candidates for immunotherapy, but if you are, then they're getting Gem/Cis/Durva. Things are changing rapidly. These are cisplatin eligible patients, and now for cis ineligible patients, we're getting EV Pembro. And very soon we'll get the approval for cis-eligible patients for EV Pembro.
So what are the percentage of the patients in the whole of the United States? They are now actually doing immunochemo, bearing your own insured.
Yeah, that's a really good question. I don't know the answer. I would say just from attending meetings, my sense is that in academic centers, most of us are using it. I'm not sure what the uptake is in the community, but it is permeating much faster. I think there was a question in the chat asking me whether I do ctDNA prior. The answer is yes. We're doing ctDNA prior to any therapy, prior to neoadjuvant therapy, after cystectomy. So we are actively checking ctDNA on all patients.
Okay, now just moving on to the NMIBC. So again, we have a couple of trials like your CREST, Potomac. They have shown some sort of benefits, but then what are those patients in whom actually you would like to give immuno with BCG?
Yeah, that's also a very good question, and I think I've answered this before. In very high risk patients in whom you really don't think cystectomy is going to be an option, in non-muscle invasive bladder cancer, patient with extensive CIS, some bladder symptoms, high grade T1, multifocal high grade T1. These are very, very high risk patients, and we often talk to them about upfront cystectomy given the risk factors. So that would be a patient who, if they're refusing cystectomy altogether and they're not a good candidate for radiation therapy given extensive CIS, then we would potentially offer them BCG plus maintenance if we have it, and consider doing checkpoint inhibitor in those patients. So very high risk, I would say it might be a thought.
So what actually all these trials have shown, this immunotherapy works well only when you add BCG induction and maintenance. So what we need actually we are having a global shortage of BCG. What we need actually something to replace BCG. What all these immunotherapies are doing, actually they are doing on the top of BCG induction and maintenance. So is there anything that you can think of, or is there anything on the horizon that can actually completely replace BCG and it will be a new standard? In case of, because there is good BCG shortage now.
Yes, good question. So there are a few trials where we're trying to replace BCG altogether. Like I said, we do have recombinant BCG from ImmunityBio, which we're using. Probably the biggest trial right now, which we don't have results for, is the Sunrise-3. And Sunrise-3 is the intravesical drug releasing system with gemcitabine, IDRS they call it now, but it has many names, TAR-200 or the Pretzel. And that's the Sunrise-3 study is looking at the Pretzel, the IDRS versus IDRS plus citrullimab versus BCG. So we'll see if that is a potential. The other one is gemcitabine docetaxel. And of course, the bridge trial will let us know if that is an alternative for BCG.
Okay, thank you. The final question: since this immunotherapy is now actually coming into NMIBC space, immunotherapy used to be given by the medical oncologist. So is there a time now the urologist to start giving immunotherapy also? Because
that's what we call a loaded question in the U.S. So I don't know how many medical oncologists are on the call here, but yes, this is oftentimes debated in the U.S. Sasanlimab, which is the subcutaneous formulation of checkpoint inhibitor, I think the idea from the company was that urologists would be using this. There's a lot of debate about management of AEs. And there are some centers, mostly in the community, though, that are delivering checkpoint inhibitor because they've been doing systemic therapy for other cancers for a long time, for prostate cancer, for renal cancer. So there are some LUGPAs or large urology group practices in the United States that are routinely administering checkpoint inhibitor. But yeah, the point of the subcutaneous formulation was that you would get this into the offices of urologists for those who want to. In academic centers, we work very closely with our medical oncologists, so there's really no need for that. We work collaboratively with them, and we refer to our medical oncologists for therapy.
Okay, thank you very much for your nice introduction. Now we'll move on to the next talk by Professor Ananya Chaudhary. I would request Dr. Sanjay Adla to introduce and then take the session forward.
Thank you very much.
Thank you.
Thank you very much, Prof. That was excellent.
Thank you.
I'm going to introduce Professor Ananya Chaudhary, honorary consultant in Christie Hospital, and she is the group leader for translational radiobiology, or more importantly, anything that we need to know about bladder preservation therapy. She is the person to go to. So Ananya, you can start.
Thank you so much. Let me share my slides. Okay. Hopefully you can see them.
We can. If you wanted to do the slideshow, please.
Yes, will do. Okay. So thank you very much for inviting me to speak to you all this evening. I'm going to talk to you about, I guess, practical things to know about radiotherapy-based bladder preservation. I've got to admit, I just used to call this bladder preservation, but my medical oncology colleagues seem to want to hijack the phrase to use it for systemic treatment only, and I guess that might be a point for discussion later. These are my conflicts of interest. So I think it's fair to say that for a long time we've been debating amongst ourselves about the outcomes of surgery versus radiotherapy for bladder cancer, and I have to admit, I think we need to stop doing this debate. I think at worst we can say that the outcomes are similar. And actually, if you look at contemporary data, I'm going to tell you very controversially that the outcomes from radiotherapy with a radiosensitizer are actually better. And these are the two most recent publications that show this. So surgery is no longer the gold standard for muscle-invasive bladder cancer. I don't think we need to debate it anymore. And this is going to be my starting point. There are lots of factors that can impact treatment choice, both clinician choice and patient choice. I think many of these factors are actually prognostic rather than predictive. And there are actually very few factors, I think, that mean that patients can't have the ultimate choice. So the factors that favor radical cystectomy, I think, are poor bladder function, inflammatory bowel disease, and previous pelvic radiotherapy. However, I have given bladder preserving radiotherapy in patients who have any of those factors. I think the factors that favor bladder preservation and radiotherapy are, most importantly, the desire of the patient to preserve their own bladder, and patients who are high surgical risk, who surgeons that I work with do not feel they should operate on. And all the other factors, including some of the factors that I know people use in their decision making when selecting patients for radiotherapy, I believe are prognostic factors. And therefore, patients who have diffuse CIS, hydronephrosis, more advanced tumors and multifocal tumors have all get radiotherapy if that's what they choose to have within my practice. I'm really pleased to say that in the last few years, there have been some real advances in the international guidelines that we all use to map our treatment. It's taken a while to get there, but it's very pleasing to see that the American guidelines as well from 2019 acknowledge the role of chemoradiotherapy, as it's called. I prefer radiotherapy with a radiosensitizer, both as standalone treatment or after neoadjuvant or downstaging or induction chemotherapy, whatever you want to call it. And there are reasons why radiotherapy is often the preferred treatment of choice, especially for patients. I think there is increasing data, this is data from India, showing that actually, if you look at a lot of patient-reported outcomes and you ask patients how they are after treatment, there isn't a lot to choose between either cystectomy or radiotherapy, except for when you look at sexual function and actually body image as well. With sexual function and body image, it has been shown in a number of studies that radiotherapy is the preferred option for patients for obvious reasons. Certainly when we give radiotherapy, even if the nerves get a dose, the damage to them is likely to be less than with a cystectomy. And even though body image with a neobladder could be comparable to that of radiotherapy, the vast majority of patients in most countries who undergo surgery for muscle-invasive bladder cancer do not get a neobladder. They end up with a urostomy, which obviously can be unsightly and can cause some concern for patients. So I often get asked about giving neoadjuvant chemotherapy with radiotherapy because there are no phase 3 randomized controlled trials purely with radiotherapy and a radiosensitizer. But there is a trial, actually one of the largest trials ever done, that's really quite old now and was published in 2011, showing that neoadjuvant chemotherapy is advantageous whether patients have surgery or radiotherapy. This was an international trial called the MRC BA06 trial. Patients were randomized to neoadjuvant chemotherapy up front, and then patients went on to have either surgery or radical radiotherapy with almost equal numbers in both groups. And most importantly, there was no interaction for treatment type. So regardless of whether the patient had surgery or radiotherapy, there was a benefit to neoadjuvant chemotherapy. And I think at this point it is important to acknowledge that when radiotherapy is given with a radiosensitizer, the systemic treatment is a radiosensitizer. It is not trying to replace the role of neoadjuvant chemotherapy. We often use different agents, they're used at different doses and used in a different way. And I don't think we should equate neoadjuvant chemotherapy with radiosensitization. But there is a question about which perioperative chemotherapy, and as Sia described, the world has moved on, but there is data to suggest that there are different outcomes with different cisplatin-based chemotherapies. The VESPER trial is a French trial. It compared perioperative chemotherapy with either dose-dense MVAC or gemcitabine cisplatin. And you can see here from the progression-free survival curves, there is a clear advantage to patients getting dose-dense MVAC compared to gemcitabine cisplatin. In a lot of countries, this trial means that where patients are suitable for dose-dense-MVAC, they have been getting that rather than gemcitabine cisplatin. I think we can discuss why dose-dense-MVAC may be better. Is it because you're giving 4 drugs rather than 2? Is it the intensification of the systemic treatment? And where you give the same number of cycles, is it the fact that you're giving the chemotherapy in a shorter time period? And it could be all of these factors that mean that there may be better outcomes using dose-dense-MVAC compared to gemcitabine cisplatin. And I think it's important to consider this because when we move on to talking about perioperative immunotherapy combinations, none of those combinations have been compared to dose-dense-MVAC. And where the benefit is marginal, I think as clinicians managing our patients, we need to be aware of that. But as we've already discussed today, new standards are here. We have Niagara-style perioperative chemotherapy or periradical treatment chemotherapy, which is how I would like it to be interpreted, with gemcitabine, cisplatin, and durvalumab. And in a lot of practices, this has now become the main standard of care for patients having radical treatment for muscle-invasive bladder cancer. And in some practices already, EVP is here. And if it isn't here already, it probably will be within the very near future. Are all patients suitable for these treatments? Is there still a role of cisplatin-based periradical treatment therapy? I don't think we know the answers to that. And I think in lots of practices, we're all finding our way as to how we select the right treatments for the right patients. There's absolutely no doubt in my mind that you can get significant side effects from checkpoint inhibitors, and those of us who are used to using them in the metastatic setting do have some patients where the benefit from checkpoint inhibitor, even if their disease is fully controlled, is not always that clear. In the UK, we are great believers in radiosensitization. This is data from our last national study, where you can see that about 2/3 of patients got radiosensitization, and about half the patients who got radiosensitization also got neoadjuvant chemotherapy. Interestingly, compared to a lot of the rest of the world, we don't really use cisplatin, and we can go into why that is, but we use low-dose gemcitabine, mitomycin C and 5-FU, and carbogen and nicotinamide. And do these patients, having had their non-surgical radical treatment, do they get good quality of life? Well, again, this is data from a multi-center international study led in the UK. So this isn't just data from centers who have big practices, who are believers and quite zealous about doing bladder preservation. These are small centres, large centres, and not just UK data. And as you can see here, when you look at patient-reported quality of life, the outcomes are really very good, and patients are very happy with their outcome. This is data out to 2 years, but we have data from longer follow-up from older studies, and it shows similar outcomes. So this is good treatment, and I think it's important that as a multidisciplinary team, we make sure that we discuss it with our patients so our patients can make informed decisions. You can see here the outcomes from the data. Again, these survival outcomes for local regional invasive disease control are excellent, and I think are comparable to any surgical series that is published. And importantly, we treated bladder alone. the pelvic nodal recurrence is low. We have all moved to moderate hypofractionation in the UK based on the individual patient data meta-analysis of the BC 2001 and BCON studies, which showed that 55 Gray and 20 fractions is actually superior to 64 and 32 fractions in conventional fractionation, with superior outcomes, with no increased toxicity, and with fewer resources for both departments and for patients. This seems like a no-brainer to me. I'm briefly going to cover node-positive disease because this is an area where sometimes we're not clear what to do. This is data from a UK-based retrospective multi-centre study where we showed that if patients are suitable for intensified stroke radical-like treatment, they do better than if they're treated with palliative intent. We also showed that the outcomes are more like metastatic disease than localized disease. And although radical cystectomy and radiotherapy outcomes are similar, these patients really don't live that long. So for these patients in our practice, we would preferentially treat them with non-surgical means if they have a good response to induction chemotherapy. So this is our, if you like, flow of bladder preservation within the clinic. All of our patients have a TURBT. They go on to have neoadjuvant chemotherapy and then radiotherapy with a radiosensitizer, and then follow-up has to be very strictly done with support from the urology team because the patients need to have regular cystoscopies and CT staging so that we can pick up any local recurrence or metastatic recurrence early. So optimal bladder preservation for muscle-invasive bladder cancer, it's all about patient choice, patient selection. No one is too old for appropriate treatment. I treat patients in their 90s quite regularly. At present, for most of the world, I think it is still cisplatin-based chemotherapy, although checkpoint inhibitors in combination or EVP is on its way. I always use radiosensitization. There's no patient who can't cope with a bit of carbogen, which is enriched oxygen, even if they're not suitable for chemotherapy as a radiosensitizer. We use hyperfractionated radiotherapy, reduce overall treatment time by improving the workflows, and we wouldn't have the data that we have if we didn't recruit to clinical trials. And finally, I think we do have some challenges for the future. We need to ensure that we have treatment options for patients of all ages, all comorbidities, and in all healthcare systems. I think that's the advantage of us getting together for webinars like this, where we can share ideas and practice. As a non-surgeon, I need to have buy-in from my surgeons so that the appropriate patients are referred, as many patients don't even know that radiotherapy is an option if surgeons don't give them that information. We need to be better at personalizing treatment. We don't have any radiosensitivity biomarkers at the moment, but we can give patient information and use the data that we have to help them choose the best treatment for them. And we need a better understanding of the biology of the target and biomarker definition to further personalize treatment in the future. Thank you very much.
Thank you very much, Dr. Chowdhury, for that talk. I'm just going to ask a couple of questions that have been raised. So the first one would be, before the patient goes down the line of the TMT, would you like us to do as good a resection as possible? Because there is always a difference between American way, wherein they're just doing a TURBT for biopsy purposes and sending them for TMT, or as good a TURBT as possible and then go down the line of TMT.
So I think all surgeons, especially those who are specialists in bladder cancer, will do the best TURBT that they can. And I think if they can't do a complete resection, that's because there's a bulky tumor, there's a tethered tumor, there are complexities.
Sorry, the question was more related to you in that do you think there is a difference in the outcomes between a complete TURBT? Let's say a patient has been referred in and you can see that there is a mass there. Would you again refer them for another redo TURBT? Or do you say actually it doesn't make a difference, I'll go ahead with RT?
Well, I think the surgeon does the best TURBT they can. So if there's any disease left behind, that is a prognostic factor, not a predictive factor. So, and the bladder path study, right, suggests that an MRI with a biopsy is probably as good as a TURBT, certainly if you're looking at the final outcomes for the patient. I think the important thing is not to delay the treatment by repeating procedures if they don't need to be repeated.
Okay, thank you. The second one is, as with respect to radiation oncologists, is the learning curve with respect to radiotherapy for prostate is quicker or shorter compared to radiotherapy for bladder, or you think it's an organ and there should not be any learning curve with respect to that?
Well, I think there's always a learning curve for us. We surgeons and radiation oncology is a craft specialty. I think there are things to be learnt from volume of experience as well. Certainly, there are patients that we are happy to treat that sometimes colleagues in other centres aren't. But I don't think it is as difficult as some of the surgical procedures that surgeons do. I think if you know your anatomy, if you have good imaging and you have good guidelines and some experience, then you can do a pretty good job of giving radiotherapy.
Okay, we are running 15 minutes. So the last question that I would like to ask is, whenever you have gone down the line of TMT, we generally tend to look for local recurrence. But what is the proportionality of local recurrence to systemic recurrence or metastatic recurrence for patients who have had TMT?
So it is definitely stage dependent. So there's a difference in outcome between T2, T3, T4, as you would expect, just like you see in surgical series. The local recurrence in our practice is between 10 and 15%. The majority of those are non-muscle invasive bladder cancers. And the actual risk of local recurrence from muscle invasive bladder cancer is less than 10%. But the risk of metastatic disease is similar to that which we see after surgery. And depending on the T stage, it can be as high as 50%.
Okay. And you would not give standard RT. You would always like to give them with some sort of a chemosensitization along with RT.
I think there is a radiosensitizer for everyone, and therefore I would always give a radiosensitizer. It doesn't have to be chemotherapy.
Okay, thank you very much. Thanks a lot.
Thank you.
Thank you. Okay, Brisbane, you can take over and then move on to the next session.
Yeah, the next session will be conducted by Dr. Puneet and Dr. Gopichand. I request Puneet to can you take it over and start the next session of muscle invasive bladder cancer?
Yeah, thank you, Dr. Vishwanu. So we'll be moving on to the next session, which is the muscle invasive bladder cancer. And essentially, we have heard a great talk from Dr. Ananya Chaudhary. Now, we'd be essentially discussing about the intricacies and nuances of cystectomy. So I would like to request my first speaker, Dr. Anup Kumar, who is going to talk on robotic versus open radical cystectomy. And he is professor and head of department at Safdarjung Hospital, New Delhi. Dr. Anup, please go ahead with your talk.
Good evening, everyone. If I'm audible and my slides are visible.
Yeah, please go ahead.
Thank you very much, USI and ICU, for giving this opportunity. So the topic is how do we choose between the open versus robotic radical cystectomy in the today's era. So we all know radical cystectomy is a urological challenge with a significant morbidity in urology. But with the advent of robotics, there's a trend towards using total intracorporeal radical cystectomy, and this is gaining momentum worldwide. So I will be discussing in brief about all these outcomes with the best published literature so far. And in the end, I will tell you how to practically decide when to go for open or robotic cystectomy. So this is the highest quality literature evidence available till date. The CORAL study, which is RCT comparing open versus robotic versus lap radical cystectomy, the 5-year follow-up study. Then we have a RAZOR trial, which is originally non-inferiority RCT, but then there was secondary analysis published. Then this was a Cochrane database systematic review with the 5 RCTs with 541 participants comparing open versus robotic with comparison of various outcomes. And this is again one of the best evidence so far. We have systematic review and the meta-analysis with comparison of 8 RCTs with 1024 participants comparing open and robotic cystectomy. So we compare all these best availability available literature. This is the gist of the outcomes. We talk about operative duration is significantly higher in the robotic arm as we expected by around 76 minutes. Blood loss is again higher in the open arm with a more requirement of blood transfusion and more chances of venous thromboembolism in the open cystectomy. However, the 30-day complication rate, 90-day complication rate, and the post-op ILS were comparable in both groups, and the length of stay is higher in the open cystectomy group, despite the use of the ERAS protocol in both the arms. The positive surgical margins and lymph node yield is again comparable in both the groups. And if we look at the 3 years overall survival and progression-free survival, is comparable in both the groups. And we look at the 10 years survival outcomes. This is Mayo's Clinic experience comparing open versus robotic. We can see there's no difference in overall survival, recurrence-free survival, and recurrence rates. Coming to the quality of life outcomes, we talk about EORTC questionnaire and the FACT VCI questionnaire. RIRC fared better in physical functioning or well-being domain. Rest all other parameters were comparable with the open arm. And we look at the functional outcomes, sexual and the voiding function. Although the robotic cystectomy arm is deficient in the sexual function, most of the data we have is in the open arm. And if we look about the economic differences, definitely the robotic arm has a higher healthcare cost as compared to the open arm. And if we talk about the urinary diversion, which is totally intercorporeal, and this systematic review comparing the open versus intercorporeal, it shows that intercorporeal diversion with the conduit, they fared better in terms of 90 days complication rates, despite the downside of a longer operating time, which is we can understand that in intracorporeal there will be higher operating time. And in intercorporeal new bladders, again, this study shows that the intercorporeal new bladder shows lesser blood loss, lesser complication rate, and lesser 30-day readmission rates with improved daytime continence. So this is a very interesting study published in the latest EUA guideline 2026, that if we go for radical cystectomy robotically with the extracorporeal conduit, there's a higher chance of ureteroenteric anastomotic stricture because there's a more chance of extensive dissection of ureter extracorporeal. So this is something you have to take into account because of the impaired blood supply. So this is the important practical consideration. So in my opinion, as per the all available literature, when can we recommend for open cystectomy in today's era? Patients with severe cardiorespiratory comorbid conditions who cannot tolerate anesthesia or pneumoperitoneum or reverse Trendelenburg position. Patient with multiple open abdominal surgeries requiring a lot of additional issues which might prevent the access to the minimally invasive surgery. A locally advanced cancer with a bulky disease with perivesical extension, needing extensive manipulation. Here, open cystectomy will be better. A palliative cystectomy, especially after post-chemo radiation, these cystectomies are betterly done with the open arm. And if your robotic system malfunctions in between, when you're doing the robotic surgery, then the answer is you complete the cystectomy with a laparoscopic approach and you do extracorporeal diversion. Of course, if you have a lack of robotic trained operative assistant, which is very vital for these kind of surgeries, then I think you should go for the open one. And if you are working in an academic center, then of course for resident training, I think open radical cystectomy should be taught to these residents, and that is one of the indicators. If you are a new robotic program starting in your center, you should have adequate open radical cystectomy experience, an adequate robotic experience. Then you should first start doing only the robotic cystectomy part with extracorporeal diversion in simple cases. Then with the more experience, with the more proctors and mentor help, you can graduate to intercorporeal conduit and intercorporeal new bladder subsequently. So this is how I think, in my opinion, the practical consideration, how you choose. These are the patients for open cystectomy. Rest all, you can go ahead and do the robotic cystectomy with the intercorporeal diversion. So I want to conclude that robotic platform has distinct advantages in the radical cystectomy. However, the open cystectomy continues to be the gold standard. As a budding urologist, he or she should learn open radical cystectomy, but as they gather more experience, they can graduate to a minimally invasive robotic cystectomy with total intracorbal diversion. Thank you very much for your patient listening. Any question, I will be very happy to answer.
So thank you, Dr. Anup. Questions we'll be actually having at the end of the session. So because we are already running late, I will request you to please stay back. So we'll go to the second talk, which is by Dr. Amandeep Arora, and he would be talking about whether to do a standard or extended lymph node dissection and how do you choose among that. So Amandeep, please go ahead with your talk.
Yeah. So good evening. My slides are seen, right?
Yeah, please go ahead.
Yeah, thank you so much. So there is absolutely no doubt that a radical cystectomy is the standard of care for muscle-invasive bladder cancer. For a minority of our patients, about 25% who tick the boxes for bladder preservation, we do offer them bladder preservation. But for the vast majority of our patients with muscle-invasive bladder cancer who do not tick boxes for bladder preservation, we do surgery. And when we do surgery, lymph node dissection is an integral component of that surgery. There has been no trial comparing lymph node dissection with no lymph node dissection. So we are not very sure about the therapeutic benefit, but there is lots of retrospective data, large retrospective data, which shows better survival with lymph node dissection. Hence, we say that lymph node dissection in bladder cancer has staging benefit and probable therapeutic benefit. There is absolutely no debate whether we should be doing lymph node dissection or not, just as we do debate sometimes in our prostate cancer talks. So the question is how much to remove, not whether to remove or not, but how much to remove. And that depends upon where do the bladder cancer cells drain to. So this is a study which looked at where does bladder cancer drain to, and it drains to these nodes in the pelvis that you see. So the distribution is external iliac lymph nodes, internal iliac lymph nodes, and obturator lymph nodes for the bulk of the disease. May skip to common iliac nodes in 15% of patients and may go to the lower retroperitoneal nodes in 4% of patients. The templates that have been defined are the standard template, which is bounded laterally by the genitofemoral nerve, medially by the ureter, caudally by the circumflex iliac vein, or the cloacaeus lymph node, or the lacunar ligament, whatever you might want to call it. They're all close by, and cranially limited by the bifurcation of the common iliac artery. That is the template, and it is done bilaterally. And because it's the standard template, it will include the external iliac, internal iliac, and the obturator lymph nodes. Now, extended template is standard plus the common iliac lymph nodes. So everything till the aortic bifurcation is removed, which also includes the presacral lymph nodes. Now, we have level 1 data about comparison of these templates. This was the first trial that was published, the LIA trial, the lymphadenectomy extent assessment trial, which was published in 2016 in European Urology. 2018, sorry. So this was the first phase 3 RCT assessing the extent of lymph node dissection in bladder cancer. It compared the limited template, not standard. It was even smaller than standard with the extended template. But the extended was actually the super extended template, which went up till the IMA origin. So it compared a very small template with a very larger template. These are the main results. So the median number of nodes dissected in the limited template were 19, much lesser than in the extended template. And as you can see, the 5-year RFS, the 5-year CSS, and the 5-year OS were numerically decently higher in the extended group. However, they were all statistically not significant. And that is why the conclusion of the trial was that extended lymph node dissection failed to show a significant advantage over limited lymph node dissection in respect of all survival outcomes that they studied. Now, why was this trial negative? Because intuitively it should feel that the trial should be positive. So this study aimed to show a difference of 15%. That is how the sample size was calculated. And this 15% difference was probably a little overzealous. About 14% of patients in the trial had T1 disease. And we know that T1 disease patients do not have lymph node mets. And hence there is probably no role of checking whether to remove more nodes or less nodes in them. The limited group had 19 median number of nodes removed, which is much higher than in older studies. So this could have diluted the difference between the two arms. And finally, about close to 10% of patients in both groups had positive margins, which is a pretty high number. And this could have diminished any beneficial effect of removing more nodes because you're doing an R plus resection finally. This is the second trial which has recently been published last year, the SWOG S1011 trial, published by Dr. Seth Lerner and the group. So they looked at 300 patients with standard template and another 300 with extended template. The primary outcome was the disease-free survival. And as you can see, there is absolutely no difference that they found. We need to note very carefully that 70% of these patients were T2 patients and only 20% of patients were actually node positive in final pathology. So the results need to be taken in mind with these two things understood, that most of these patients were not at a risk of having nodal mets. Now, what about the toxicity? So grade 3 to 5 adverse events, 54% in extended, 44% in standard, 90-day mortality substantially higher in extended lymph node dissection versus standard lymph node dissection. So the conclusion of the authors was that extended lymph node dissection provides no survival benefit over standard lymph node dissection, which is well taken. But they also went on to say that it has higher peri-op morbidity and mortality, which was shown in the results. But I think that that is probably an incidental significant finding, because just removing one extra batch of common iliac and presacral lymph nodes should probably not contribute to an extra 5% 90-day mortality. And this is something which they probably incidentally found. In fact, Seth Lerner himself wrote in 2020 that concerns about perioperative complications should not be a barrier to selection of the extent of lymph node dissection in our patients. So finally, we should always perform a bilateral pelvic lymph node dissection. There is no question about it. Level 1 evidence says that extended is not better than standard lymph node dissection, but this level 1 evidence exists for patients in the trials in which they included 70% more T2 patients. And the approach does not matter. Finally, clearing the template does. So you may do it in the open, laparoscopic, or robotic way. Finally, after you've cleaned, that is how the lateral pelvic wall should look. Thank you. Sir, I think you're muted. Cannot hear you. Punit, sir.
Yeah, hello.
Yeah.
Yeah, thank you so much for finishing on time. We'll be asking the question in the end. Let us go to the next talk, which is by Dr. S.K. Raghunath, and he would be talking on intraoperative spillage during cystectomy. Sir, please go ahead and carry on with your talk.
Yeah, thank you, Dr. Puneet.
Yeah, we can see you.
Can you see my slides?
Yes, yes.
Yeah, 1 second. I'll just make it maximum. Yeah. Thank you, Dr. Sanjay and Bruchbanu, for this opportunity. I would like to talk about intraoperative spillage during radical cystectomy. As a surgeon, all of us perceive it's a dreaded complication whenever intraoperative spillage happens. Either it is urine or the tumor, direct tumor. So let's see. So clinical relevance and definition. What is the definition of spillage? It is either exposure of urine containing tumor cells or tumor into the peritoneal cavity or operative field during surgical manipulation. This commonly happens by direct bladder entry during dissection, unintentional tumor violation, particularly in large tumors, or urine extravasation from the bladder. As a surgeon, this is a core fear for all of us, that peritoneal seedling leads to recurrence. So what is the pathophysiology of this seedling? Because tumor cells are known to exfoliate, which are there in the urine circulating, and whenever it implants, it is likely to grow. But key insights are not all exfoliated cells are capable of implantation, because many cells could be dead. So it is the tumor biology, cell viability, and host immune response are critical determinants, not just the spillage. So what are the mechanisms and high-risk scenarios? What are the mechanisms are bladder entry, inadvertent bladder entry, tumor violation, and particularly this happens during friable tumors and large tumors, or when you have done a radical TURBT or multiple TURBTs where the bladder is very thin. While doing radical cystectomy, you may enter the bladder at this particular site. What are the high-risk scenarios where it happens? Probably while doing salvage cystectomy in presence of a tumor where you don't have the right planes, you may enter the bladder. Post-radiation fibrosis, particularly dome tumors when you're doing open cystectomy, because usually you're going to use your hand or some instruments to retract that, applies a lot of pressure over the tumor. So that's where spillage happens, or it happens in diverticular tumors because there is no muscular wall to the diverticular tumors. So clinical awareness is very important. Recognizing these mechanisms enables proactive prevention and rapid response when spillage occurs. What is the evidence and reality check? If 100 spillages happens, we see peritoneal carcinomatosis only in less than 5%. This is based on retrospective cohorts and systematic reviews. And despite of spillage, gross spillage, the port site metastasis is seen in less than 1%. Is there any level 1 evidence? There is no level 1 evidence for this. But the absence of proven impact does not justify complacency. Prevention remains paramount, but fear should not drive the surgical decision making. So what are the drivers of recurrence? It is not the spillage, it is the tumor stage. Next, the node positivity, margin status, and tumor biology. In the descending order, you can also make out the hazard ratio. If tumor stage is higher, the hazard ratio for recurrence is 2.5 to 4 times. The spillage impact, not independently prognostic in multivariate analysis. When tumor stage, nodes, and margins are controlled, spillage loses its statistical significance. When it happens, more commonly with open surgery or robotic surgery, it happens more commonly with open surgery because during robotic surgery, magnification is very high. You are less likely to enter the bladder because of precision and less compression we use during robotic surgery. So what are the prevention strategies? Whenever you anticipate in a larger tumors, better to clip the ureters early so that urine does not come into the bladder. Strict extravesical dissection, particularly where the tumor location is there, try to go extra wide, and minimal tumor handling, which is very important, particularly during open surgery. So prevention is paramount by considering these 3 principles. So clinical intraoperative rules: never squeeze the bladder, particularly while doing radical open cystectomy. Avoid entering the lumen. Maintain the en bloc principles. If spillage occurs, what you are supposed to do in emergency response protocol is immediately suck out if the urine comes out into the field or if the tumor spills into the field, and use normal saline, sterile saline. Use probably 2 to 3 liters so that it will dilute and it will remove all the circulating tumor cells. And there is no guidelines level 1 recommendation for this, but generally all the retrospective series says that proceed oncologically, you complete cystectomy. That's what is the recommendation. So key principles are: do not panic, document clearly, and no change in the adjuvant strategies. What you are going to document: time and extent of spillage, immediate response action, what you have done during that time, and what is the irrigated volume of saline you used, and whether completion of the procedure you have done or not. And there are in the literature, instead of saline, many series have suggested to use even intraperitoneal gemcitabine or mitomycin, but there is no level 1 evidence for that. So debate: does spillage matters? Certainly it matters. It's a theoretical risk. Biologically plausible mechanisms are there because viable tumors are there in the urine. Peritoneal seedling is a possibility. It is well accepted. But the verdict is spillage is a theoretical concern that demands preventive measures but should not drive the surgical decision making or cause undue anxiety. So take-home messages: spillage is definitely undesirable. You should always prevent that one, but it is not an independent prognostic factor. The biology of the tumor determines the destiny. So it is not the drop of urine or the tissue which comes into the field, but the nature of the tumor that defines the outcome. Thank you.
Thank you so much, sir. It was a very nice talk and a practical issue which you have very nicely summarized in 5 minutes. I would now request my co-convener to co-present.
Thank you, Dr. Puneet. I would call Dr. Raghavan. Dr. Raghavan is a senior consultant uro-oncologist, Apollo Hospital, Chennai, and adjunct professor at TN MGR University. He is going to talk upon prehabilitation for radical cystectomy. Sir, take over, sir, Dr. Raghavan.
Thank you so much to USI.
You're audible and your slides are visible.
Good evening, all. Thank you so much to USI and all the leaders in this meeting. Thank you so much. So, people have heard a lot about ERAS protocol. This is a pre-RAS protocol. Why prehabilitate is what we are trying to explain now. So, first question is, what is prehabilitation? Prehabilitation is a process of getting somebody ready. For example, somebody doesn't run a marathon in a day. They coach themselves, they prepare themselves to run it. Radical cystectomy and especially conduit diversion or any bowel handling is the biggest killer in the radical cystectomy and the biggest problem in the cystectomy process. Hence, getting these patients ready is the most important key of success as well. So, why should we do it? Because this chart beautifully tells you what happens when you don't prepare somebody. They have a deep dive down before they come. However, if you prepare them, that dip is a smaller dip. We all know that radical cystectomy is an operation with high mortality and morbidity. And most of the patients are old, frail, anemic, borderline HB, smokers, borderline cardiac functions. And we also know largely that these patients are tiny bit immunocompromised as well. So there is everything that is playing against them. So we try to do something in order to make them better so that they can do the surgery. Okay. So we look at all the components: physical, mental, financial, and sexual. That's how I tell my students, and that's how I want to present here as well. What physical component should we do to make them better? The most important thing is nutrition. Make sure the waiting time whilst they are waiting for cystectomy, which is anywhere between 1 to 3 weeks, they go into a high protein diet. Every tiny bit helps. If they are vegetarians, there are protein mixes available, pulses are available. I am a strong believer of probiotics. Having a patient optimized in the gut flora is a good way to recover their bowel function post-operative. You mandate them to have an exercise regime for at least 45 minutes to 1 hour a day. This could be some form of walking, strength training, plank, whatever they could do within the capacity, but it is mandatory. Respiratory prehab is a mandatory in our unit as well. Incentive spirometry, 10 times every hour for at least 10 to 12 hours a day, which is 120 to 150 times. Make sure they are sent to a cardiologist and optimize their heart functions. They may have an EF of 54, 48. By just doing a tiny bit of manipulation of the drugs, you will have them in a much more optimal state. Most of these patients have hemoglobin of 10, 9.6. So during the waiting time of 2 weeks, you can give them intraoperative iron and B12, which will definitely pop up the hemoglobin by 1 or 2 points. Stop smoking doesn't need to be said. It is mandatory. Why is it important? It really changes the cardiovascular, pulmonary function of the patients, improve the muscle, improves the insulin function, and therefore the post-operative recovery of these patients are tons better. We all believe, we all know this, but it is equally important to understand mental rehabilitation, mental prehabilitation is equally important. These patients go into depression because they are suddenly told that you're going to have, it's a lifestyle changing operation that they're going to undergo. So you have to consider that, introduce them to a stoma nurse, a stoma therapist, give them the adequate preoperative counseling. My stoma therapist spend at least 2 or 3 sessions with them, each session about 1 to 2 hours of session. We need to sit and clarify everything. We have to take them on board with us. The side effects, complication, the journey post-surgery, ensure that they get adequate rest and sleep. Yoga and meditation is very useful. I encourage them for yoga and meditation. At least 50% of my patients follow that plan. Financial, it's important in our country. It may not be important in other parts of the world, but it is very, very important in our country. Explain them the cost. What is the cost of the surgery going to be? What are the costs if they have any complications? What are the costs of additional treatment? It has a huge impact on the patient's decision-making process, and therefore it has to be done much ahead of the surgery. It is equally important that we are genitourinary surgeons. A negative impact on the sexual function is almost always going to happen. Look into that. Make sure men are put on the prehab program. My andrologist put them on low-dose Mildafil as well as vacuum erection devices at least 2 to 3 weeks. They may not be sexually active, but if you're going to do a neobladder, after the surgery, they'll have shortened penis, which cannot be useful for them to pee, or it will spill on the legs. So it is important to make sure they go on a prehab program. In women, consider organ preserving surgery for them in selected appropriate patients. So this is just a map to show you that the whole thing is important, and this has been studied well. It is not something I'm coming up and telling you now. It has been studied well that all these components have to be looked into and advised. Thank you so much for listening. Prehab is actually tons more important than rehab, and we all have to start the EROS protocol at least couple of weeks ahead of your cystectomy or any major surgery. Thank you so much.
Yeah. Well said, Dr. Raghavan. Next, we have Dr. Debanshu Bansal. He's a consultant urologist and renal transplant surgeon at Jaipur. Dr. Debanshu Bansal is going to talk on ERAS in Indian scenario. Dr. Debanshu Bansal?
Yeah, just a minute. I'm just trying to share my screen.
Yeah.
Yeah, so I'll be talking about ERAS protocol for radical cystectomy in India. And as we discussed in our previous
The
presentation,
slides are not there.
can you
Yeah,
hear
you
me?
have not shared, Dr. Debanshu.
Yeah, I'm trying to do that.
Yeah.
Okay, shall we go to the next one and come
Yeah,
back?
we will come
Yeah,
back to
you
you.
can. Yeah.
Yeah, we can come back to you. Is it okay?
Yeah, that's okay.
Yeah, Dr. Ravi Mohan is there. He doesn't need any introduction. He is going to talk on neobladder pros and cons of Gonem, Studer, and Hotman
Yeah.
procedures. Yeah, Dr. Ravi Mohan.
Yeah, thank you, Dr. Sanjay, Brusubano, and Puneet and Gopichand and USI ISU for this opportunity. I think this is more scheduled like for residents because so a disclaimer that there are no pros and cons for any type of neobladder. It is one neobladder which you practice or which you have seen during residency and keep on doing it, and you will have good outcomes. So there is no literature which has compared each of them in one go. So individually, people have mentioned what are the side effects. We're just going to discuss those. The core of all this is that you convert a high pressure ileum into a low pressure reservoir by detubularizing it, and people have done it many ways. So what Hartman did, it was essentially a W pouch where he has detubularized it and created a spherical and used chimneys on both ends to anastomose the ureters. In fact, there are in the previous earlier papers, he also used a nipple valve kind of reimplantation, but most commonly is the chimney which is being practiced. Gonim again did a neobladder with the same W configuration, but then he implanted the uterus through the line tunnel, thereby decreasing the length of the bowel which was being used, and it has been reported to the best excellent outcomes. Studer, probably the most well popularized, and we all know Dr. Studer. Everyone must have met or read him during their lifetime in their journey. That Studer has popularized this neobladder across. And if you remember his talks where he would take a balloon and show how a spear, what is the pressure in the spear versus the. So what he essentially does, he takes about 40, 50 centimeters bowel and creates first a horizontal U and then rotates it so that it becomes a spear, and takes a longer segment to implant the ureter and thereby decreasing the, it's a refluxing anastomosis, but it minimizes because it's a longer loop. Now, Hotman typically uses 70 centimeters, Tudor is 55, and Gonim is variable, but Gonim again essentially uses 45 to 50 centimeters because there is no extra bowel required for the ureteric implantation. So we already covered this. So across all the literature, individually, the papers have mentioned that the daytime continence metrics and the nighttime continence metrics are almost similar in all the three types of comparison. There's a little difference here and there, I think, but since there is no direct comparison, we cannot really answer it. But Studer being Hartman being the oldest and Gonim being the youngest. Again, with respect to outcomes, remember that because Gonim is using a kind of line tunnel where there is higher chances of stenosis because it's a non-reflexing anastomosis. Whereas in Hartman and Studer, it is still a reflexing anastomosis, but the reflex doesn't happen because the ileal loop takes care of the reflex because of the low pressure zone. So the stricture, ureteral strictures is highest with the Gonim pouch. In all of it, remember that we cannot negotiate or we cannot compromise with the fact that we should select the right patient rather than using the right technique, because the technique which works well for you is the right technique rather than anything else. And what is our experience? Probably I was given this talk because we have done almost all the types of neobladder. In the older times during open era, we were doing mostly the Gonim pouch and Switzerland tunnel. Now we modified it to Hartman's one because the Switzerland tunnel was getting difficult, especially in obese patients. But in robotic era, we did initial Studer's pouch and there was some confusion. Now we shifted to Kelly's or pyramidal pouch, which is again modification. As I said, it is more important that you master one and give a good outcomes. So what is the verdict? There is no one answer to whatever we do. It is what we do. We should continue to do it, and you'll have a best outcome. To address pros and cons, I think because Hartman is using a larger bowel segment, you are bound to have a little more metabolic complications than the Studer pouch, which is using the shortest segment of bowel. But again, since there's no comparison one-to-one, we can never answer it in reality. Thank you very much.
Thank you, Dr. Ravi Mohan. We'll go back to Dr. Bansal. Dr. Devanshu Bansal, you are there? Dr. Devanshu?
Am I audible?
Yeah, you're audible. You can share your
Yeah,
screen.
let me just try to share my screen, okay?
Yeah.
Okay, is my screen shared?
No.
Are you able to see my presentation?
No.
No. Okay, just a minute. It is showing me that it is sharing here.
Okay. No, we are not able to see. Or you can just present the
I'll
gist.
just talk about it.
Yeah,
Okay.
just fast.
So
You can
yeah,
just finish it
yeah.
off.
So
Yeah.
I'll be talking about the
Iras.
ERAS protocol for radical cystectomy in India. And as we have seen in the previous presentation, the ERAS protocol is one of the new components that have come up for urological surgeries nowadays. And it was first introduced in colorectal surgery in 1997. And the main purpose of ERAS protocol was to reduce the surgical stress response. And the ERAS study group was then created in 2001 to provide surgery-specific pathways with patient-centric and multidisciplinary interventions, incorporating the best available evidence-based management to reduce the surgical stress response, optimize the physiological and organ function, and achieve early recovery. And in 2013, urological guidelines were given by the ERA Society, although still there is very limited Indian data. And the AUA guidelines have given the ERA's guidelines for urological surgeries in 2024, which incorporate almost 22 components, including nutritional counseling, smoking cessation, avoiding routine mechanical bowel preparation, giving preoperative carbohydrate loading, using a restricted transfusion strategy, maintenance of normothermia, avoidance of intraoperative fluid access, using mechanical and pharmacological DVT prophylaxis, and use of peripheral mu-opioid receptor antagonist, that is albumin. Now, if we search for studies for ERAS protocol in India, only three studies come up in the results. The first is the study by Tamanka et al., which have implemented the ERAS protocol in robot-assisted radical cystectomy. This was published as a retrospective cohort non-comparative study, and all the patients underwent robot-assisted radical cystectomy with intracorporeal ileal conduit urinary diversion. a total of 35 patients underwent the surgery from 2016 to 18. And the main interventions that the surgeons did was using carbohydrate loading till 2 hours prior to surgery in non-diabetic patients. And the surgeons did not use any epidural catheter, although the ERAS protocols usually recommend a thoracic epidural. Apart from that, chewing gum, sham feeding, limiting the intraoperative fluid access, early removal of nasogastric tube, using only a single drain, that is a parietal catheter, were used, and albumopan was not available. And the authors said that the ERAS protocol was feasible in robotic-assisted radical cystectomy and intracorporeal urinary diversion, and the overall results were favorable. The RT could be removed at the same day, the parietal drain could be removed in 2 days, and the median days of passing the flatters was 2.5 days, and passing stools were 4 days. There were no open conversions and no mortalities. The second study is about integrated ERAS protocol in radical cystectomy, and it was a comparative retrospective cohort study done in SKIMS, Srinagar. In these, 47 patients underwent cystectomy according to the ERAS protocol, and they were compared with 47 historical cohort patients who underwent radical cystectomy according to the traditional practice. And the main interventions that were used in the ERAS protocol in this study were an addition of
Dr. Bhattali, you have muted. You have to unmute. You have to unmute. Yeah, you have to yeah.
Yeah.
I think there was some glitch in his this thing because now it was sharing the screen.
Yeah, you can summarize. I think you have finished with the talk also.
You can stop sharing now.
Yeah.
Devansh, you just summarize.
I think he is not audible, and anyway, he has
Devansh, do you want to
finished with the
summarize in
talk
couple of
also
sentences?
nearly. Yeah.
Devanshi, are you there?
Yeah, I'm here. Can you hear me
Yeah.
now?
So
Yeah.
just tell your final slides. Just read out your
Okay.
final slides.
Yeah.
So the second study said that the overall complication and the length of stay was less in the ERAS group. And the final study was a randomized control trial that was done by us in 2017-18 with a total of 54 patients. And we used the similar protocol according to the AUA guidelines, except for the albumin, which was not available. And we found that the intraoperative complications were less in the ERAS group, but the length of stay was same in both the groups. So to conclude, ERAS protocol for radical cystectomy is still evolving, and there are new components that are available in India like the carbohydrate drinks, but the mu opioid antagonists are still not available. The total Indian data is limited. There has been shown that the bowel recovery improvement is there in ERAS protocol, but there is a doubtful shortening of the length of hospital stay and more studies are needed. Thank you.
Yeah, we'll go for some questions, Dr. Bushbanu.
Or Gopi, can you summarize the session, whatever there have been, and if there are any pertinent questions?
We've already actually over
Yeah,
crossed
we are over. That's
20 minutes. We're really sorry for that, but please can you quickly. Puneet.
Yeah, I'm here. So thank you all the speakers for great talks. I think just regarding Dr. Raghu's talk regarding the spillage, there were like some factors which favored spillage. So Dr. Raghunath, I just wanted to ask one question and then we will summarize regarding that. So for your bladder neck or the do you clip the catheter, or do you have spillage from that area, or it is basically how do you manage that bladder neck or prostate? Sometimes you have the opening is bigger there. I think he's muted and.
Dr. Raghu, please unmute yourself.
So I think we will summarize because we are already late.
Yes.
Yeah. So I there were some great talks. We know that Dr. Anup talked about open plus robotic. So nowadays, if you are experienced enough and you can do robotic surgery, there are, rather than the surgical indications, it is more of a anesthesia indications, or if there were some previous surgeries, adhesions in which you think there may be complications, then you can go for open. Otherwise, you can very well do all this with the magnification. Spillage is less, so you can very well go ahead with the robotic surgery. Aman's talk regarding lymph node dissection, I think we all do now standard lymph node dissection rather than extended. And the point which he also pointed out, that it should not lead, the extended should not lead to increased mortality unless the disease itself or the selection bias is there for the patients in which the extended lymph node dissection was done. Otherwise, for just for the nodal dissection point of view, it should not lead to more mortality. Dr. Raghu has already spoken about the spillage. Dr. Raghuvan's talk regarding prehabilitation, there was a question from Dr. Ravi regarding the prehabilitation at the time of neoadjuvant chemotherapy. So if Dr. Raghuvan is there, he can just point out regarding that. I think IRAS, we are already, all of us are following now, and that study which Ashwin did, Ashwin was our fellow, and at that time we studied around 35 to 40 patients, and that was still not a very large number, but we have been following that from last 10 years now, and in most of the patients IRAS protocol we can do. So I think that concludes.
All right, Puneet, can I answer that question? Sorry.
Yeah, please. Yep.
See, always before dividing the urethra, we make sure ureters are clipped.
Yeah.
So by doing that, you're likely to prevent. But when you are dissecting the bladder, sometimes spillage happens before even, control the ureters. So you should be careful about that.
Yeah. So actually, what my question was regarding the apex, from the prostate apex. Sometimes, we usually clip the catheter, but sometimes it slips out or something. So do you do something differently in that? So that was the only thing which I wanted to.
So I inflate the bulb,
balloon
and pull balloon and pull the catheter, apply a gold clip.
Yeah, that's it.
So can I make a comment about that?
Yeah.
So it's very difficult sometimes to clip that catheter as well, if you've realized during robotic. So what we do is just before clipping, once you've dissected the apex, we remove the catheter, clip it at that level, at the level of apex with the clip. That's very easy. Once you've removed the catheter, that's a soft tissue, it can be clipped, and then you cut it. So there is no spillage. And like in open, you don't need a catheter to pull to give traction. In robotic, or anyway, you complete the dissection, and apex is the last one you handle.
Yeah, so I think both the ways are there to do that, and usually we don't find it that much difficult to clip the catheter as well if you are using a gold clip.
Can you move on? Actually, it's already 10 here. Please.
Yeah. So yeah. So thank you all. Dr. Pashwan, you can take over and.
Yeah, there's nothing more to say. Thank you, the ISU, for the opportunity. All those speakers actually wonderful talk and discussion. I just want to hand it over to Dr. Surya Prakash for final words.
Yeah, thank you very much, Dr. Brusubanu. First of all, on the behalf of Indian School of Urology, I would like to thank Dr. Sanjay Adla, Dr. Brusubanu, and all the office bearers of oncology subsection, especially Dr. Brusubanu. You have made a wonderful program. Though we have crossed the time, I think it's worth attending. All these talks are very, very valuable for the postgraduates. And all these talks are recorded and they're available on the e-learning platform. Anyone can go back and see those talks. And my special thanks to international speakers, Dr. Dinesh Mand and Dr. Ananya Chaudhary, for the excellent presentations. And all the faculty, many thanks for your wonderful talks. Thank you very much. Is Dr. Keshav there? Dr. Keshav, sir?
He's there. He's there.
Thank you, all the faculty. Many thanks to the international faculty. I think it was a wonderful session on bladder cancer, and it will be a treasure for the postgraduates. Thank you very much.
Thank you. Thank you, sir. Thank you, everyone. Thank you. Good night. Thank you.
Good night.